Any questions?
Thank you so much for the amazing presentation. One question in the chat about next steps for Kidney Check project.
So with the Kidney Check project, the screening is all done now. The funding was finished at the end of November of last year. So I know there is some money coming into Manitoba, but it won't be for screening. It's more of getting the information out there and just planning, I guess, for further projects that will be happening in Manitoba. But the screening, as far as kidney screening with the Kidney Check project, that's over right now. So it's unfortunate, but we're hoping to expand because our services at the Diabetes Integration Project, so we do that in 18 communities. So we're trying to expand it so that this type of service is available in every First Nation community in Manitoba, but it's an ongoing funding battle.
Yeah, and one of the things that we actually have come to believe at Kidney Check is that it's a public health issue, and that people need to be screened. And there's been papers out in terms of the amount of dollars that are saved to be able to not only improve people's quality of life, but to be able to give that information, just the information and the awareness about kidney disease, which we provide in terms of the Kidney Check project, but also to be able to have people to have access to screening. We believe that that's a public health issue, and so we continue to knock on doors and see what we can make happen here in Manitoba, because we believe it's very important. Manitoba has the highest burden in Canada in terms of kidney disease. Kidney disease for non-Indigenous people, as Tanis talked about, is 1 in 10 if you're non-Indigenous. If you're Indigenous, it's 1 in 4. And if you live in a rural and remote community, it's 1 in 3. So we really need to be doing more in terms of making sure that people are screened. I'm excited about the new medications that are out there because they've been proven to work, and we need to make sure that people are aware of them and have access to care. And that was the main thing about the Kidney Check, was to provide access to care and to provide access in a holistic way, and to work with our partners. We've trained nurses in communities to be able to do their own screening when available, and we found out that the best way to do it is for Tanis and her nurses to go into the community and work with them and train with them. And then from this program, from this Kidney Check program, we also had, in combination with Red River College and the Kim organization, under the direction of actually Carolyn Chartrand, who was one of the original nurses on is still with the project and one of the original nurses on the Finnish project, put in a module in their diagnostic. They have diagnostic service workers, which are basically the healthcare workers or healthcare aides in the community, or even like healthcare representatives in the community. And so they take them into a program, and that they have incorporated the 12 hours of training of how to do point of care testing within the community. And that training and everything was developed from the standard operating procedures that Tanis and her team, we had developed them for the Kidney Check, but her team has taken and enhanced those and updated them and continue to update them as we move along. And so the actual content for the program was taken from our standard operating procedures. And I believe to date that they've graduated 24, Tanis?
I think so, yeah.
Yeah, and there's another cohort that's supposedly starting in September. So we're really excited about the reach and everything that we created within the program. Any more information, Tanis?
No, I don't think so. I think that's it.
Good.
Thank you so much for this wonderful presentation and sharing sharing about this experience that you've done. It sounds like a great initiative. And looks like people in the chat hope that you can secure some funding as well.
Yeah.
We'll keep trying.
Yes, we will. We never give up. And the other thing too is that we're also looking for more individuals on our CANSOL team, on our Indigenous Peoples Engagement Research Council, and also on our Kidney Check project to just keep spreading that knowledge in terms of things. So you can get in contact with Jocelyn. Maybe you could post your information in the and Tanis your information in the chat, and we'll be able to help populate our teams and keep moving forward. Kidney Check is also going in BC, Alberta. We had a program within Saskatchewan, and also we're hoping to there's one in Ontario. So it's something that is national, and we really need to keep going in terms of that. And if you can't find any information, just go on the CANSOL CKD website, and we're all there. Megwitch.
Thank you. Thank you again, Kathy and Dennis, for sharing your experiences and perspectives with us today. On behalf of the CDTRP Patient, Family, and Donor Research Forum, thank you both for your leadership, your partnership, and for helping us better understand how collaboration between communities, patients, and healthcare providers can drive meaningful change and improve health outcomes. I hope you have a wonderful day.
Thank you. Thank you for inviting us.
Thank you.
Thank you. Thank you.
All right, so we'll move on to our third presentation, Indigenous Kidney Health Project. So I'm pleased to welcome our next speaker, Crystal Hardy, for her presentation on the Indigenous Kidney Health Project. Crystal Hardy is an Ojibway doctoral candidate in health sciences at Lakehead University and coordinator of the Indigenous Kidney Health Project at the Ajmera, I never say that correctly, I apologize, Transplant Centre, University Health Network. Her research focuses on First Nations experiences of kidney disease, dialysis, and transplantation, with an emphasis on improving transplant pathways, care continuity, and culturally responsive kidney health services. Grounded in Indigenous methodologies, community-engaged research, and two-eyed seeing, her work integrates Indigenous knowledge systems, clinical can't say this word either, epidemiology, and health services research to advance more equitable kidney care for First Nations patients and communities. Thank you for bearing with me through that, and over to you, Crystal.
Hi, thank you so much for the introduction. I want to apologize for my voice. I'm a little bit under the weather today, so going to be keeping my camera off. I think Emmanuel was going to share my slides for me. Emmanuel?
Yeah, we'll be sharing them, MC.
Okay, awesome. Sounds good. Oh, just give me a second here. Okay, let me know when you're ready, Emmanuel. I want to start out. Yeah. Okay, thanks. Anim Buju, Mino Gijagad, Sagawan Aquan Dishnakas, Makwa Ndodem, Binjdwabak Saging and Ishnabek and Dunji. So good afternoon, everyone. Thanks for being here today. My name is Crystal Hardy. As Kendra said, my spirit name is Rising Sun Woman, and I belong to the Bear Clan and come from Rocky Bay First Nation, which is located on the shores of Lake Nipigon in northwestern Ontario. I do want to say I have lived experience with chronic kidney disease as well. I was diagnosed with end-stage kidney disease in 2018. I received a kidney pancreas transplant in 2021. And then unfortunately the graft failed earlier last year, 2025. So I am currently awaiting another transplant, and I am also receiving hemodialysis in center at Toronto General at the University Health Network. I'm a PhD candidate in health sciences at Lakehead University, as Kendra said, and this work is conducted in partnership with the Ajmera Transplant Centre at the University Health Network under the supervision, of doctors Isfan Mucci, Chris Musquash, and Charles Levko. Today, I'll present the Indigenous Kidney Health Project, a coordinated program of research dedicated to advancing equity in kidney care and transplantation for First Nations peoples. I'll move through 4 parts. So first is the human and epidemiological case for this work. Second is the structural reasons these inequities persist. Third, the 3 interconnected research projects that constitute the Indigenous Kidney Health Project. And finally, the pathways forward, which this evidence will be translated into action. This is deeply personal work, and it's grounded in relationship, community, and commitment to meaningful change. Next slide, please, Manuel. Before I present data, I want to begin with a story. It's a representative case, a composite drawn from documented First Nations patients' experiences. And it illustrates what the statistics will show in terms of what is actually happening in a person's life. So consider a First Nations man from a remote fly-in access community in northwestern Ontario. He's diagnosed with kidney failure. There's no dialysis available in his community, and he's told he must relocate hundreds of kilometers away from his home to Thunder Bay to receive hemodialysis treatment, not temporarily, but permanently. To secure housing in Thunder Bay, he sells his rifles, tools of subsistence, and of connection to land, culture, and food sovereignty and security, and his vehicle, and he surrenders his house on the reserve, where housing is critically scarce and waiting lists are extremely long. Once that home is given up, there is no returning to it. His community is in a very real sense gone to him. In Thunder Bay, he begins hemodialysis, 3 sessions per week, every week. He manages this entirely alone. No family, no elders, no community, no one who speaks his language or understands where he comes from. In a city that's not his, without the relationships that sustain wellness and recovery for him. He is then referred to Toronto for transplantation, Canada's largest metropolitan center. For someone from a remote First Nation of a couple hundred people, the cultural and geographic distance is almost incomprehensible. Again, no navigator is assigned and no supports are arranged. He goes alone. He receives his transplant under the best possible circumstances, and he is discharged to a hotel room in downtown Toronto. Post-operatively, he dresses his own wounds, manages a complex medication regimen, and arranges his own blood work appointments, follow-up clinics, and pharmacy visits. Alone in a city he doesn't know well. And so what I ask you to sit with is this. This is not an exceptional story. It's the norm. It's what systemic inequity looks like when it is translated from population statistics into a single human life. And that is what the Indigenous Kidney Health Project aims to address. Next slide, please. So why it matters, the epidemiological picture confirms what the story suggests. First Nations peoples in Canada experienced chronic kidney disease and end-stage kidney disease at approximately 2 to 3 times the rate of non-Indigenous populations, as documented by the Canadian Institutes of Health Information and the CanSolve CKD network that you just heard. The literature further indicates that disease onset occurs earlier, progression is much faster, and comorbidity burden is greater among First Nations patients. Yet access to kidney transplantation, which is the gold standard treatment offering the highest survival and quality of life for most patients with kidney failure, is markedly inequitable. In some northern regions, Local estimates suggest transplant referrals may be up to 4 times lower than in urban centers. These disparities are not explained by biology or individual behavior. They are rooted in systemic, structural, and historical factors. Because transplantation is demonstrably superior to long-term dialysis, equitable access is not an administrative aspiration, it's a life-saving imperative. And so, the Indigenous Kidney Health Project responds to this gap by combining research, community engagement, and system-level partnership. Next slide, please, Manuel. Ontario data make the scale of this inequity concrete. Naylor and colleagues in work published in 2025 using ICS and CIHI data, our health administrative data, documented major regional variation in access to kidney transplantation across Ontario's regional renal programs. Approximately 10 transplant referrals per 100 person years in Northern Ontario, compared with approximately 29 per 100 person years in Toronto. So patients in the north are being referred for transplantation at roughly 1/3 the rate of those in southern urban centers. First Nations patients are also significantly less likely to receive preemptive transplant, and that is transplantation before dialysis is ever required, or a living donor transplant, which are the modalities associated with the best long-term outcomes. The Ontario Renal Network further reports that Indigenous patients travel on average 4 times further than non-Indigenous patients to receive care. So critically, the available evidence indicates that these gaps are not attributable to patient preference, non-adherence, or clinical ineligibility. They are the products of structural and logistical barriers operating at every point along the care continuum, from diagnosis through referral and evaluation to waitlisting and transplantation. Next slide, please. So why do these gaps persist? The barriers are multi-layered and mutually reinforcing, and I would group them into 5 main categories if asked to do so. First, geography and relocation. Many First Nations patients face extraordinary travel distances, as I just mentioned, to reach dialysis centers and transplant programs. For some, treatment requires permanent relocation with the attending loss of housing, community, and connection to land, culture, and traditions. These are impossible choices. Second, system navigation. So care is fragmented across primary care, nephrology, and transplant programs. Referral pathways are inconsistent, and patients are frequently left without guidance through these complex clinical processes. Third is a cultural mismatch. Patient education and clinical communication frequently lack cultural alignment, which produces the erosion of trust and potentially undermines meaningful shared decision making. Fourth, colonial and structural factors, as you heard in the previous presentation. There are jurisdictional gaps between federal and provincial responsibilities. Institutional racism, increasingly recognized in the literature as a determinant of health for First Nations peoples and communities, and the broader legacies of colonialism. These remain embedded within the health system structures today. So the literature also documents related patient-level barriers, including home environments unsuited to home dialysis, the cost of utilities and heating, food insecurity, and fear of social isolation or exclusion. And fifth, living donor barriers. So smaller potential donor networks exist. There are travel-related financial strains and limited living donor education. And these all reduce access to transplantations with the best outcomes. These barriers interact and compound one another. Addressing them, therefore, requires both systems level change and deeply relational, culturally grounded approaches, which is precisely the dual orientation of the IKHP, or Indigenous Kidney Health Project. Next slide, please. Before turning to the IKHP's research components, I want to situate this work within the broader ecosystem of First Nations kidney health. So most notably, Kidney Check, which you just heard about in great detail, the community-based screening program developed within the CanSelf CKD network. Kidney Check brings mobile screening directly into First Nations communities, integrating hemoglobin A1C, estimated glomerular filtration rates, and urine albumin to creatinine ratio testing with on-site education and coordinated follow-up. And so crucially, Kidney Check is not a program delivered to community. It's co-developed, as you heard, with and led by Indigenous communities, embedding cultural safety and relational trust as foundational design principles. And it also operates in accordance with the First Nations principles of OCAP, ownership, control, access, and possession. The evaluation evidence is encouraging on this front. Participants report increased trust, engagement, and motivation to pursue follow-up care. And early detection really matters enormously here because identifying kidney disease early enables timely intervention that can prevent progression to kidney failure, thereby reducing the very relocation burden I described earlier. Kidney Check demonstrates what becomes possible when Indigenous self-determination is placed at the center of health system design. Next slide, please. So now I'll move on to the Indigenous Kidney Health Project and what that is. The Indigenous Kidney Health Project itself is not a single study. It's a coordinated and evolving three-part program at the moment of research, with each component building upon the former. And so the first component, which was my doctoral internship project, is now complete, and it mapped the landscape of kidney care for First Nations patients, identifying system strengths, gaps, and challenges across the continuum of care. The second is my doctoral dissertation, a 2 to 3 year mixed methods investigation, pairing qualitative key informant interviews and dialogue circles with a retrospective cohort medical chart review, examining both lived experiences and clinical metrics across the full continuum of care. The third is a 5-year nationally significant study advancing health-related quality of life measurement for First Nations adults. Excuse me, because we can't improve what we can't measure, but we can accurately, and equitably measure. And so together, these projects generate knowledge that is simultaneously relational and empirical, qualitative and quantitative, and critically grounded in First Nations governance and partnership from beginning to end. Next slide, please. We'll start with Project 1, which was my doctoral internship. So the internship project was the IKHP's foundation. Its purpose was to establish the landscape of the continuum of care for First Nations renal patients, mapping system strengths patients, identified challenges and structural gaps from early diagnosis through to transplantation from the perspective of those closest to the work in the system. Methodologically, the project employed qualitative key informant interviews guided by relational accountability and the OCAP principles, of course, with 4 participating groups. The first comprised healthcare providers across the renal continuum, so nephrology teams, nurses, and allied health professionals. The second comprised patient partners with lived experience of kidney disease, dialysis, and transplantation, whose knowledge is invaluable in this context. And the third comprised interest holders and kidney health system stakeholders who shape policy and programming as it relates to kidney disease and kidney health. And the fourth comprised First Nations leadership and community representatives whose perspectives on governance, self-determination, and community priority are essential to define what change must look like. The project's contributions were twofold. It identified where the system supports First Nations patients and where it fails them, and it surfaced additional priorities across navigation, referral pathways, culturally safe communication, and the relocation burden that we mentioned earlier, which directly informed the design of my dissertation and grounded the broader research program in the realities of First Nations patients and communities and the realities that they live with every day. Excuse me. Next slide, please. Next is project 2, which is my dissertation project, and it's currently underway. And this is the full continuum of care. So my dissertation translates that landscape established during my internship into a mixed methods investigation of the full kidney care continuum. It's designed as a 2 to 3 year project, as I mentioned in the brief introduction of it, conducted in partnership with the Association of Iroquois and Allied Indians, the Anishinaabe Nation, the Ontario Renal Network, CanSolve CKD, Lakehead University, Thunder Bay Regional Health Sciences Centre, and the Ajmera Transplant Centre at the University Health Network in Toronto. It comprises 2 interconnecting strands. So the first strand is qualitative, critical Indigenous participatory action research project design, implemented through semi-structured key informant interviews of 45 to 75 recruited and patients, and dialogue circles of up to 6 participants. So using purposive maximum variation and snowball sampling, we will recruit approximately 35 to 45 participants across 4 groups. First Nations patients living with chronic kidney disease who are receiving dialysis or are in post-transplant care, family members and caregivers, healthcare providers and administrators, and community leadership and policy representatives. Data collection will occur at the regional level programs, so at Thunder Bay Regional Health Sciences Centre and at the University Health Network in Toronto. And these will follow local protocols, so with opening and closing prayers, elder guidance, and gifting where appropriate. The methodological framework is deliberately integrated. Indigenous story work following Archibald Position's storytelling as both pedagogy and data. And then I also employed 2 seeing, of course, following Bartlett, Marshall, and Marshall. And this brings Indigenous and biomedical worldviews into respectful interface. And then I employ tribal critical race theory. And this theory provides decolonizing analytic lens on how colonial policies, jurisdictional frameworks, jurisdictional fragmentation, and systemic racism shape renal care experiences and healthcare experiences. And then participatory action research principles, primarily the principles of reciprocity, relevance, and respect, as well as shared power. And this shared power positions community partners as co-researchers rather than subjects. Analysis will integrate Indigenous story work with reflexive thematic analysis, and trustworthiness will be established through triangulation, audit trails, member checking, and community validation sessions. These community validation sessions will be complemented in accordance with the Indigenous standards of relational accountability. And the second strand of the dissertation project is a retrospective cohort study at Thunder Bay Regional Health Sciences Centre, enrolling approximately 200 participants, of whom we expect roughly half to be First Nations. So there are two overlapping cohorts that will be assembled: a dialysis cohort of adults on maintenance dialysis, and a transplant cohort of patients followed at the Thunder Bay Regional Health Sciences Centre who have received a kidney transplant between 2021 and 2025. The primary exposure is self-identified First Nation status or membership. The primary outcome is a composite of transplant waitlist status and initiation of transplant workup. Secondary outcomes include preemptive and living donor transplantation, dialysis modality, age at initiation of kidney replacement therapies, and access to the multi-care kidney clinic before dialysis initiation, alongside time to event outcomes such as time from dialysis initiation to waitlisting and time from dialysis initiation to transplantation, and time from waitlisting to transplantation. Analytically, we'll use logistic regression and Cox proportional hazards ratios, adjusting for age, sex, distance from the dialysis center, education, income, diabetes, and the Charleston Cox comorbidity index, with multiple imputations by chained equations for missing data. Based on local clinical experiences, an expected waitlist proportion of approximately 25% among non-First Nations participants versus 10% or lower among First Nations participants. The study is has approximately 80% power to detect the difference. And so ethically, the project operates under strong Indigenous governance, community advisory council of First Nations patients, caregivers, elders, and Indigenous health care leadership guide all stages of this research. Data are grounded under OCAP through formal agreements, and the study complies with Chapter 9 of the TCPS2 Tri-Council Policy Statement, with plain language consent materials further provided and translated into Ojibway, Cree, and Ojibwe Cree as needed. Oral consent will also be employed in order to honor oral tradition. The two strands are integrated through a convergent parallel mixed methods design, allowing us to triangulate lived experience against clinical metrics so that we can ask what patients are experiencing and understand precisely where the numbers confirm and where they diverge from these experiences. Next slide, please. And next is Project 3, which is a 5-year study measuring kind of some of the important metrics. The third project is the IKHP's most far-reaching. It's a 5-year study conducted under the governance of the Association of Iroquois and Allied Indians, again, an Anishinaabe Nation, that asks a fundamental question, and that is, are we measuring health-related quality of life accurately and equitably for First Nations adults? The study pursues two objectives. The first objective is to co-develop and validate the adult health and well-being measure, the AHWM. This instrument adapts the Anishinaabe, the Children's Health and Well-being Measure, which itself was co-developed with First Nations partners and evaluated using item response theory as well. And that was for, you want to co-develop that or adapt that rather for First Nations adults. And what distinguishes the AHWM is its holistic conceptualization of health, integrating spiritual, emotional, physical, and relational dimensions of wellness and well-being rather than the fragmented biomedical constructs underlying most Western outcome measures. For example, anxiety, depression, individualized symptoms. And so development proceeds through 4 phases. First, relational engagement and conceptualization through community-led sharing circles, patient partner workshops, and elder and knowledge keeper guidance, engaging approximately 40 to 60 First Nations adults. Second, item creation with community partners with a steering committee approval of the items that come forward. And third, cognitive interviewing with approximately 25 to 30 adults to confirm comprehension, cultural resonance, and emotional safety. And fourth, field testing and psychometric evaluation, reliability testing, construct validity, and factor structures with approximately 300 First Nations adults. The deliverable is a complete toolkit. The instrument scoring and interpretation guidance and culturally safe reporting translates. And so this will be governed permanently by First Nations partners under OCAP, meaning that communities will retain ownership, control, access, and possession of both the data that emerges from this project and the tool itself so that they can apply it to determine their own wellness measures and determine how it's applied more broadly. The second objective evaluates whether the Promise 29+2, which is the health-related quality of life measure used in non-Indigenous or Western biomedical systems, is one of the most widely implemented patient-reported outcome measurement systems internationally used. And so this measure was developed without First Nations representation, and so functions equivalently for First Nations adults. We're hoping that this adaptation will be far more responsive to the needs of First Nations adults. We'll recruit 600 First Nations adults at Thunder Bay Regional Health Sciences Center, Sioux Lookout Minoyawan Health Center, and member First Nations of AIAI, or the Association of Iroquois and Allied Indians, and the Anishinaabe Nation. And then we'll compare their responses with an existing nationally representative sample of 1,600 non-Indigenous Canadian adults. So based on prior literature, we hypothesize that the social roles domain and the mental health domains, so factors such as anxiety and depression, will show the greatest differential item functioning, which is the possibility that the same item measures something different or that it measures it differently across the populations. The analytic strategy for this project proceeds in 4 steps. First, graded response item response theory modeling, consistent with Promise calibration standards. likelihood ratio testing for uniform and non-uniform differential item functioning, with false discovery rates corrected for multiple testing, and ordinal logistic regression confirmation of flagged items, and critically, evaluation of the practical impact on promise T-scores, distinguishing statistically detectable differential item functioning from practical meaningful measurement inequity. Flagged items will also be interpreted collaboratively in structured sense-making sessions with patient partners, an elder, a knowledge keeper, and an advisory council of health leadership, First Nations health leadership, so that statistical findings are filtered and interpreted through First Nations understandings of well-being. And so why does this matter so much? Because if the instruments we use to assess symptoms of well-being and quality of life do not function equivalently, then the clinical decisions that are made around health and well-being and the resource allocations and cross-population comparisons built upon those frameworks may be systematically biased. Measurement equity translates to opportunities for health equity. Next slide, please.
All right, Crystal, I'm just going to chime in and give you a warning about the time and have you wrap up shortly.
Sure, yeah, sure.
Thank you.
Okay, so research without action is insufficient. Across all three projects, the IKHP is oriented toward evidence that can be translated into meaningful change along 5 pathways. First, collaborative navigation, embedding Indigenous navigators who work alongside clinical teams to improve communication, build trust, and ensure continuity of care across the journey from diagnosis to transplantation. Second, culturally responsive education, co-developed patient-facing learning tools that are both accurate and culturally grounded, supporting genuine shared decision-making. And third, measurement that matters. So tracking time to referral, workup completion, and waitlist activation, disaggregated by Indigenous specific identity, so that inequities become visible in the data and actionable in policy. And fourth, knowledge mobilization, so returning findings to community and practitioners through workshops, relational dialogue, and community first plain language summaries, rather than purely academic publication. And fifth, relational implementation, holding to the principles that change must be led by and accountable to First Nations communities. And so that partnership and respect they're not additions to good research design, they're foundational to it. And then we're going to apply that. Next slide, please. We'll apply that in Thunder Bay. These are some of the Thunder Bay priorities. Next slide. So I want to close with a principle that has guided this work from the beginning, and that is that when governance, navigation, and culturally coherent education align, when First Nations hold authority over their own health data and decisions, when Indigenous navigators are present and trusted, and when the tools we use measure and communicate health accurately, as reflected by First Nations worldviews, then time to transplantation, we hope, shortens and lives can be saved. And so the Indigenous Kidney Health Project really aims to move beyond simply being a program of academic research. It aims to become a commitment to relationship and to show up consistently, listening deeply, and doing the hard collaborative work of changing systems that have failed First Nations peoples for too long. Next slide, please. There's some acknowledgements. Primarily, I want to thank the elders, knowledge keepers, and the Community Advisory Council that have worked with us on this project. Grand Chief Joel Abram from Association of Iroquois and Allied Indians, Grand Chief Dabasage from the Anishinaabe Nation, all the Indigenous leadership who have supported us, Thunder Bay Regional Health Sciences Network, Ajmera Transplant Centre at the University Health Network, Cancel CKD for their support, Ontario Renal Network for their support, and of course, my advisory team doctors is Fan Mucci, Dr. Chris Musquash, Dr. Charles Levko, and Dr. Aminu Bello, who has been supportive of this project as well. And next slide, please. There's some references. Next slide. Miigwech, thank you all for listening.
Thank you so much, Crystal.
Yeah, sorry about the time.
Don't worry about it. I just wanted to make sure that we were keeping somewhat on time, but just for those that are on the group, we are going to skip the break that we were going to take, and we'll leave some time for questions for Crystal so that she can still get a chance to share and answer questions about this great presentation and about the project that is underway. So I know there's one question already in the chat. And so the first one is, what is one major change in the health system that can positively make a difference?
I think based on the findings from my internship, thank you for the question. Based on the findings from my internship, I think the major factor that we want to address is having support through the transplant pathway. And so to support patients coming from remote First Nations into larger urban centers like Thunder Bay and Toronto, because it's a really complex process to receive a transplant and manage care. And a lot of people are traveling without supports and have to come and receive their transplants without supports. And so what we're trying to do really is, I think, first and foremost, integrate that navigation piece and find ways to in a very fulsome way, enhance navigation for patients when they're coming into these centers for care. Are there any other questions?
There's one more question in the chat. Can you tell us more about your vision for the non-academic outputs of the research project?
Yeah, for sure. A lot of community engagement. There are aspirations to travel to community so that community members don't necessarily have to travel into Thunder Bay or Toronto to see us or to meet with us, primarily Thunder Bay. So the first step, like we said, is going into Sioux Lookout and connecting with patients there, and try to make the information as accessible and meaningful to the communities as possible, to the renal patients, the providers, the family members who support care throughout these processes in the community and along the journey. And so really tailoring the information to be accessible, both linguistically and fundamentally, making sure that the outcomes are co-developed by our First Nations partners so that they are useful and meaningful to our patients and our community members. I think that's primarily our intention. Did that answer the question?
Thank you so much, Crystal, for that response. We do have one more question from Donna Stewart, and I think we have just a couple of minutes to finish that if you have time, Crystal.
Yeah, of course. Yeah.
Okay, wonderful. So Donna is asking, I'm wondering what are some ways that emotional safety can be provided to patients?
I think one is being listened to and being heard and being seen in the system. It's a very big system. And so when we're alone in that system, it can be very overwhelming. And I think emotionally, it's difficult to feel supported or stable when you're alone and trying to navigate that system. And so primarily it's how do we support patients in that process, both as care providers and as community members, as navigators, and really looking at what that looks like from the patient perspective. And so a lot of conversations, a lot of dialogue with patients, understanding what they need, what we need, and really trying to do our best to put that, to filter that through their eyes, through their lens, through their experiences, and make those changes as practically as we possibly can.